First, I would like to introduce my panel. So, Dr. Avinash Dev, Senior Medical Oncologist, Dr. Dale Rodrigues, he's a consultant surgical oncologist, Dr. Niharika Garaj, she is also a consultant surgical oncologist, then Dr. Natasha Vaz, consultant general surgeon and breast surgeon, Dr. Ajay Kose, radiation oncologist, Dr. Pallavi Shetty, radiologist, and Dr. Sneha is our oncopathologist. So, since this will be a panel for general public, so we are going to be very formal about it. Okay. So, Dr. Natasha, I'd like to ask you, since we usually surgical oncologists, they get the patient, or medical oncologists, they get the patients when the patients are diagnosed. So what are the symptoms which with which patients usually come to you, because you tend to see patients before us, to be frank.
Generally, most often, patients present to us in the OPD with maybe a breast lump that they have noticed recently, either while bathing or while changing, and a painless lump. So, what happens is because the lump is painless, they may tend to ignore it, and that goes on for a while. Sometimes patients present to us with a nipple discharge. But nipple discharge is very rarely a sign of breast cancer, hence, not very alarming symptom when patients come to us. Sometimes they may have skin changes, which they say are the early signs of breast cancer, like dimpling, puckering of the skin, a nipple inversion. In my practice in so many years, I have had a patient who once came around 7, 8 years ago with a history of a headache. She was initially referred to a neurologist, and they didn't find anything significant, so asked for a surgical opinion as well. And on carrying out a head to toe examination, the patient was also found to have a breast lump. On further investigating, radiological and histopathology proved that it was a breast cancer that had metastasized to the head and the brain, which is why she presented with headaches. Most often, in younger people, when we see younger women presenting with a breast lump, the suspicion of cancer is lesser. So a young girl comes in with a breast lump, we're thinking in terms of something known as a fibroadenoma. So fibroadenoma is basically a lump that is firm, it is freely mobile in the breast and painless. And in fact, these days it is the most commonly encountered in the OPD. So if required, we may need to do a sonography, and instead of an FNAC, directly an excision is done, mostly under local anesthesia. So when the procedure is done, the patient is talking to us, she sees us, she speaks to us, she's comfortable, and at the same time pain free. And as a dictum, anything that is taken out of the body is sent for testing, a histopathological diagnosis, which in a period of 5 to 7 days will confirm diagnosis. Now, a histopathology is a 100% tissue diagnosis. Sometimes patients present to us with breast pain in one or both the breasts. Most often, that is because of hormonal changes and something known as fibroadenosis, which is yet again another benign condition. She may happen to experience like a lumpy feeling in the breast that may be associated with a cyclical pain around the time of her periods, before her periods. In such cases, we advise patients to maybe wear a breast support, start them on Evion and evening primrose.
Oh, that's so those were the symptoms which he. So to summarize, basically, a patient will present with a breast lump or maybe a mastalgia, mastalgia being one of the most common complaint, and a nipple discharge. As she said, nipple discharge is not always pathological, and most of the time it is non-pathological. So when with all these symptoms, we usually refer our patient to our colleague, a radiologist. Okay. And as Dr. Natasha said, sometimes we do a sonography and sometimes we do a mammography. So, what do you think, Dr. Pallavi? When should we advise a mammography and when should we advise a sonography?
So, in a symptomatic patient, I think age is the criteria that we need to take into the picture. Lesser than 40 years, we should go with an ultrasound. Older than 40 years, mammography is the gold standard. It shows us much more than 40. I would suggest a younger than 40, a sonography. If it looks suspicious on a sonography, suspicious for a cancer, then you can do a limited mammography in a younger patient.
Okay, so as you said, a limited mammography in younger patients. So, when do you go for a breast MRI?
So breast MRI is a
I
problem
think
solving
young
tool.
patients, they have dense breasts, so it's very difficult for a mammography to detect cancers there which are there in dense breasts. So can you just enlighten us about it?
Sure. So MR breast is a problem solving tool. Let me again reiterate that mammography is the gold standard. But like sir rightfully said, younger patients who have dense breasts or who have a first degree relative, so we can't start screening them on mammography, but we do need to screen them because they have a high risk of breast cancer. So we can start off with MRIs just to see if they are, just to screen them to make sure that there is no cancer developing. When I say problem solving, I mean to differentiate between post-op or scar carcinomas. When there are multi-centric cancers, multifocal cancers, then you want to see better. So then the MRI comes into the picture. Another entity is an inflammatory breast cancer, which is very difficult to differentiate on mammography and ultrasound between an inflammation and a malignancy. So we'd like to, we usually go with an MRI to be able to see the morphology, the kinetic curves to make sure that this is not a cancer.
So we have done a mammography. We always grade the mammography according to the risk of cancer. So according to that, we advise the patient a biopsy. So basically, we can you just summarize the grading of mammography?
Yes. So we prefer the American College of Radiology system of grading. It's called BIRADS, or Breast Imaging Reporting and Data System. So there are grades 0 to grade 6. Grade 0 being additional imaging is required. So if a mammography has been done, then maybe we need to do sonography. If both are done and conclusive, then we need to do an MRI. Grade 1 is negative. There's no finding on the mammography. Grade 2 is benign, or 0% chance of malignancy. Grade 3 is probably benign, so it's up to 2% chance that this could be malignant. So something like a fibroadenoma would be a grade 3. Grade 4 is further divided into A, B, and C, with low, intermediate, and moderate levels of risk of carcinoma. So if you go by percentile, it's 2 to 9% is a low grade. Intermediate is 10 to 49, and moderate is 50 to 95. Grade 5 is you're very suspicious this is a cancer, so that's 95% certainty that this might be a cancer. And grade 6 is a biopsy proven cancer, which is 100% that it is a cancer. So once we have this grading system, it's a language across all modalities, like the oncosurgeon, the radiation oncologist, the pathologist, everyone understands this grading. So they immediately understand what I am thinking and how suspicious I am that this is a cancer or not. So it's a good system across all specialities to be able to communicate in the same language.
Okay, so when we have BIRADS 4, we usually go for a biopsy and we usually go for a true cut biopsy. Dr. Sneha, why do you advise us to do a true cut biopsy and not an FNA, which is very simple and can be done on an OPD basis?
So if you're suspecting a cancer, like if it's a Virats 4BC or a Virats 5 case, so we should definitely go for a biopsy because we need to do the predictive and prognostic markers. We have to save the patient's time if the patient is having cancer, and immediately if the hormone responsive therapy if the patient is ERPR positive, or trastuzumab if patient is HER2 positive. So it's definitely a better and a very good option to do a biopsy, because anyways you would have to repeat the biopsy if you do an FNAC. So better save the time and do biopsy.
So FNAC is not conclusive, biopsy is conclusive, and you cannot do any test on FNAC like ERPR, HER2 and Ki67, but we can do it on a tissue biopsy, that is a core cut biopsy. The only indications where we do an FNSA for this such kind of patient is when there is a suspicious lymph node. So such kind of patient, if it comes to you, Niharika, how would you proceed?
So, if a clinical examination, a mammography, and a biopsy is already been done, and it gives us the complete information on the clinical stage of the patient with the ER, HER2, then we start planning the management. So, breast cancer is a multimodality treatment. It's not just surgery, it's not just chemo, sometimes it's a combination of both. So, as per the current guidelines, in certain cases, Dr. Sneha emphasized that ER, HER2 is very important. So, we've done an evaluation. It's a small tumor. The nodes are probably clinically negative or radiologically negative. And if the patient is ER, positive and HER2 negative, then those are the kind of patients who go for surgery first. But suppose we have clinical situations where patients have these predictive markers as negative or a HER2 positive. Then, in certain situations, despite a small tumor size, if a lymph node is there, we sometimes have to refer them to a medical oncologist for chemotherapy and then plan surgery. Now, having said that, surgery also is multifold here. It's not necessarily removal of the breast as it used to be earlier. There are various saving options. Even after removing the breast, a reconstruction option is there. And besides that, breast saving surgery and oncoplasty is the norm these days.
So coming to some more investigation, Dale, will you do some all more investigation in such kind of patient with a breast lump? It's a biopsy proven. When do you do extra investigation apart from mammography, basically?
So if the biopsy is positive, we first need to rule out metastasis to other organs. So the simple tests are sonography of the abdomen pelvis, a chest X-ray, a bone scan, and your LFTs, CBC, electrolytes, and the basic workup that you do for the anesthesia. Besides that, we can also get a PET scan done. PET scan is not a norm, but it can be done in the affordable people.
So that is one thing, if the tumor is large, we can do a PET scan to rule out metastasis. As Niharika said, sometimes, we do give chemotherapy first, even if the tumors are small. So, sir, Avinash sir, so when do you start chemotherapy first in your patients?
Generally, what is called triple negative and what's called HER2 positive. Anything more than a centimeter probably will go for a chemotherapy first. And we complete the chemotherapy, then look at surgery, because response to chemotherapy can change what you do after surgery. ERPR is if you want to reduce size, then we go for chemotherapy. But otherwise, primarily, if the surgery can be done, I don't think chemotherapy would be given to these patients.
So basically, ERPR positive, we tend to do surgery first if it is operable, and if it is not operable, we tend to give neoadjuvant chemotherapy. So coming to you, Dr. Ajay, what are the indications to radiate a breast, basically?
See, first, though, if majority of the patients do have breast conserving surgery, so that is the first indication. If breast conserving surgery is done, you have to undergo radiation. And regarding if MRM is done, so in that case, if the tumor size is more than 5 centimeter and node positive, those patients are referred for radiations.
So basically, all the patients who have had a breast conservation surgery will go for radiation. So coming to you, Niharika, what is the difference between breast conservation and MRM, and why do you tend to do a breast conservation? Why do you push it so much if it is a small tumor,
So there
obviously,
are
and
two.
when you will not do a breast conservation surgery?
So these are completely different forms of surgery. Mastectomy means when we remove the entire breast, the whole gland is removed. And breast conservation is when we remove only the tumor with the margin of normal tissue around it, and the rest of the breast is saved. The defect herein may be filled or not. So these are the two modalities that are available. Sometimes the patient may fit both the modalities. There are a lot of factors which help us decide whether the patient needs a conservation or a mastectomy. There are certain patients for which both are possible, then it comes down to the patient choice. But there are certain situations where we have multiple tumors in the breast, or the tumor size is very large, the breast size is small, or there is a gross tumor breast discordance, then we cannot offer conservation. Now, why conservation is important? It's a choice that we give to the patient. The breast is a symbol of dignity for a lot of females. You tell them we'll have to remove your breast, they get crushed. So if you give them the option that we can treat you, we can save your breast, still remove your tumor, give you a good treatment, keep you cancer free, give you a good survival, it gives them new hope. But also important for us is to offer that safely. So we cannot compromise on the oncological safety. So these days, most of the patients fill the box for breast conservation. There are certain cases which don't, like you said, large ER/PR positive, where we give chemo first and shrink them. But certain patients are complete no for breast conservation, like multiple tumors in the breast or very small breast. In that situation, we can remove the whole breast and also have a new breast made in the same sitting or the delayed sitting. That's called a whole breast reconstruction. So these days we have these options available. We can offer these options, barring a few cases where we cannot give the option of breast conservation. But yes, it's very encouraging for the women, and they are more happier coming forward. These days, especially we see women in the age of 30 to 40 who have breast cancer. And these women, if they complete their treatment, they're going to have a long, healthy life. And if you tell them to live that life without a breast, they get very disheartened. So if you tell them that you can save your breast, you can complete your treatment, you can be hale and hearty, they more than happily take it. And there are studies that show that breast conservation, when you combine with radiation and complete the treatment, has better survival oncologically compared to mastectomy. Obviously, those studies are far and few, but that benefit is also there.
So yes, breast conservation has shown a improved survival. So before coming to the other aspect of sentinel node biopsy, I need to know something about frozen section from you, Sneha. So what is exactly a frozen section? We always explain our patients, yes, but if you tell us in a bit in detail, that would be great.
Suppose we do a biopsy. So when the biopsy comes, we spend nearly more of a day to actually process it, and then it comes to your table, and then you see it. So it takes nearly 2 days after release for the release of the report. So why not do it as fast as possible in cases of cancer? So what we do, instead of paraffin, this water component is freeze to a temperature of minus 20 degrees Celsius. So when you freeze the tissue, it can be easily cut with a knife. So this is a very precise technique where the technician has to be very much well trained to take a thin section, and then that is stained under the rapid stain. We do tall blue stain and rapid HNE stain. We cross check the sections with two stains, and then we tell the surgeons whether it's positive or negative. It's mainly important in the cases when the patient is intraoperative and one needs to know whether they need to do the whole lymph node sampling, or whether the nodes are positive or they are negative, because that will decide the further plan of action during the surgery.
So we come to sentinel node biopsy here. Dale, when do you do a sentinel node biopsy, and what are the different methods you use to do a sentinel node biopsy?
So sentinel node biopsy is indicated for patients who are node negative clinically, who have no palpable nodes. There are two methods of doing sentinel node biopsy. various methods. Three of them are for the first method is the methylene blue method, where we inject a methylene blue dye. There are different other dyes as well that can be used, but the most common one that we use is methylene blue. The second one is indocyanine green, which is a dynamic contrast where you can see the dye actually traversing through the lymphatics under real time. And the third one is technetium, which is a radioisotope. Uh, that technique usually is done with centers have a radioisotope shielded OT. The other techniques of doing auxiliary sampling and all can be done, but these are more specific: methylene blue, ICG, and the technetium.
So since technetium is in short, as we usually now use ICG and methylene blue, technetium is going to go away because it requires a lot of, you need a gamma probe and everything. So of late we are started using ICG and a combination, basically ICG and methylene blue. So when sentinel node is positive, sometimes we do complete the axillary dissection, sometimes we don't. So when we are doing a breast conservation, there are trials which have said if there is a one node positive, you can just skip the doing entire axillary dissection, the side effects of which is lymphedema. Going ahead, sir, when the node is positive, so we usually give chemotherapy to the patient. So how do you counsel them regarding the hair fall? Can you just enlighten us hair fall or the side effects and everything?
See, I think the most the effect it bothers the most is hair fall. Unfortunately, there is no way out. Two things: there are this scalp pooling, but scalp pooling doesn't seem to be working on anthracyclines, which you practically cannot omit. Other thing is to just ask them to make a good wig prophylactically, and that practically works out the most efficient solution.
So most of the patient are happy with the wig rather than.
I think so, because if you, as women, losing 50% hair has got no meaning. Men losing 50% doesn't matter. So if your statistics tell you that 50% loss is, I mean, you only the loss is reduced by 50%, and you still have 25% loss, what are you doing?
But
That's
hair transplant is a big business, sir. Even
my
if
view. That's my view. Because I feel the women cannot, 25% loss women cannot take. I mean, it is cosmetically gone. So it may be a good paper that you reduce the hair loss 50%, but 25% loss has no meaning.
And what about other side effects, sir?
Normally, see, nausea vomiting is more or less taken care, except in young women. And blood counts also more or less taken care, because intensity of breast cancer treatment is not very high. So these are the thing is venous access, which is a problem because we can only use one hand.
So, what about elderly patients? How do you manage them? That is one thing,
Okay,
they
elderly
have,
patients
because we have patients. Age is one of the risk factor for cancer. We had a 92-year-old female over here talking about her survival. So how do you handle such kind of fragile patients then?
There is limited data with older people because they were excluded from most trials. And as you move ahead of 70, the data becomes sparse. Most of these people cannot take the full dose of chemotherapy. So what your data you're getting on younger patient cannot be extrapolated. The third thing is that there is a big difference between the biological age and chronological age. And there's some people who are very fit and they take the full treatment. So generally when there's a high risk disease like heavy nodal lows, maybe large primary, maybe triple negative, where there are no other options, there probably you are on the side of chemotherapy. But if you have a ERPR positive disease, you tend to go on hormones. And HER2, it is possible to give abbreviated chemotherapy schedules for HER2, 9 to 12 weeks of paclitaxel, which is very well tolerated, weekly paclitaxel. So, actually, practically speaking, other than hair loss, the other side effects are really not something which matter.
So when it comes to elderly, Dr. Ajay, even radiation causes some side effects in elderly patients. So how
Yeah,
are there
if
anything where we can skip the radiation or any other types of radiation? Can you just enlighten about it?
So elderly, we can, if it is, if the patient is 75 plus, we can avoid, they can do only with the hormonal therapy.
So if they
And
are ERPR positive,
yeah,
basically.
yeah, ERPR positive. If the disease is very aggressive, high, heavy nodal burden, then better to give radiation, because radiation will not cause that much side effect. Nowadays, there are various technique with we can save the dose to the heart also with DIBH, deep inspiratory breath hold technique, wherein we can almost the dose to the heart is less than 1 gray. So with newer techniques, we can easily and safely deliver radiation to even the elderly patients.
So coming to, earlier we used to think, stage 4 disease, these were all operable diseases. But coming to stage 4 disease, earlier we used to think that the stage 4 disease is the end of the world for the patient, but it is no more like that in breast cancer. Sir, can you just tell us about stage 4 disease where we have some excellent results coming?
The number of options for stage 4 is increasing. The first thing we had was hormonal treatment, tamoxifen, and then the anastrozole and letrozole. Then the trastuzumab, pertuzumab solved the problem of HER2, and immunotherapy has partially solved the problem of triple negative. The problem remains triple negative because these tend to be aggressive, they tend to relapse early, but the good part is they don't relapse by 3 years, they probably not relapse. So as against, I have a patient who's relapsed after 22 years after ERPR positive. That you'll probably never have in a triple negative. By 3 years, 5 years, definitely you rarely see them relapsing again. Uh, there's a study, where I think about 5% people, women with metastatic breast cancer, will go on for 20 years. And this is the anthracycline era study. And when they're retreated, the same percentage holds again. So many of them respond again. So now we are seeing many more patients surviving for long. Like you have the CDK4/6 inhibitors. I have a patient on 5 and 6 years on these drugs, and who probably would have relapsed maybe in a year, 18 months or so actually. So a lot of agents are available now. Immunotherapy, where it works, is very good. Maybe a small proportion. Trastuzumab, and in this hospital we had a patient. She came with the entire chest was full. I never, for assessing cardiac function after many years, I got a MUGA done because you could not put the 2D echo probe. That's the kind of disease. So she went on for 4 years plus with a combination trastuzumab, pertuzumab, docetaxel, and other things. So this was something unheard of. When these things were not available.
So the only thing which we don't know is that, how long to continue these drugs. When there is disease, when there is no disease, should we stop or no, or there is no answer to it, I guess.
Usually when you reach a round figure of 1 year, something happens. Those who want to stop, they ask you to stop. But I again have a patient on TDM1 for 4 years plus now. And now because Zydus is giving it free, there's no disincentive for her to stop. She's young, of course. So normally what happens in these people is if you come to a point, hormone treatment you don't stop. But other drugs, immunotherapy you stop at 2 years as the protocol. The other drugs, when you come to 1 year and either it's causing side effect or it is expensive, then the patients keep on asking, can we stop? There are no answers to this. And one may discuss and take a view of for discontinuation, but whether that's the correct thing or not, I don't think anybody knows.
So again, coming to the stage 4 disease, there were some surgical things which were done earlier, palliative mastectomy or something like that, which have almost gone entirely now. But yes, radiation also comes into work in a stage 4 setting. So, Dr. Del, when will you refer the patient to your radiation colleague, like, with a metastatic breast cancer?
Various indications for radiation in a metastatic setting. One would be having severe pain in the back, bone meds, severe pain in the weight-bearing bones, femur. Then you refer them for radiation to that specific part of the body. Uh, Besides that, I think that's the only indication.
So, is there any other protocol which you follow when you radiate,
No,
different?
so
Yeah.
palliative radiation acts as a very good palliative treatment. Okay, so if a patient is not elderly patient and she is not able to walk around and all, so there are we can give single fraction also to that particular site where the bony pain patient is having. Even for the brain mets also we can give one single fraction or 5 fractions, or usually we give 10 sittings.
So basically, there are options for stage 4 as well as basically all the stages of breast cancer. So I thank all my panelists for taking out your time, and I hope our audience has liked our panel discussion. Thank you so much. Thank you.
With sincere gratitude, I gratefully acknowledge the participation of our chief guest, Samira Reddy, our esteemed guests, Reverend Fathers, Sisters, our senior doctors, Dr. Sister Beena, Dr. Rajiv, Dr. Nikhil, Dr. Niharika, Dr. Dale, Dr. Pallavi, Dr. Sneha, Dr. Avinash, Dr. Ajay. A special thanks to our marketing team members, headed by Mr. Roy Pereira, the technical and back-end staff. And in case I have happened to miss thanking anyone, my sincere gratitude. On behalf of our team here at Holy Families, an assurance of our concerted efforts in this new venture, an endeavor that serves as a beacon of hope and guidance. Here's Dr. Natasha Vaz signing off for the day. Adios, ciao, sayonara, thank you, and goodbye.